Okay, so let's continue our talk on toxicology now with testing.
And when most people think about testing with tox, they think immediately about the urine drug screen. And there's a lot more to be said about that as well as the other tests that are typically ordered. So one test I'll typically order includes the comprehensive metabolic panel. And with this you're going to get the lights, the blood urea nitrogen, the creatinine glucose, and the bicarb in there. Also important is to get the ABG just to see the pH. And a urine pregnancy in all women of childbearing age. And I'd also get an EKG to look at the intervals, as a lot of drugs can change those.
X-rays could be helpful in certain ingestions, especially if they are radio-opaque. And there's a common mnemonic to know which ones those are, and that spells coins, as coins are typically radio-opaque on the X-ray. Whereas C stands for chloral hydrate, cocaine packets, and calcium. O is opium packets. I is iron, but also remember any metals you're going to be able to see on an X-ray, and are neuroleptic medications, and S stands for the sustained released or enteric-coated agents. Now, since I brought up the UDS, let's talk about that. We pretty much always order it, but it almost never is helpful. First of all, you got to know which drugs are contained in your particular hospital's UDS. Each one is different. I can tell you at my hospital we look for marijuana, opiates, benzodiazepines, barbiturates, methamphetamines, and cocaine. If they took something that's not one of those, you're not going to catch it on the UDS. Additionally, the results of the urine drug screen can be misleading. Say someone presents with a barbiturate overdose, but they took cocaine the day before. You're going to see cocaine on the urine drug screen, and it has nothing to do with today's presentation. And you can also sometimes get false negative results. So the urine drug screen, we're pretty much always going to get it, but it's rarely useful. So remember, the thing that's really going to tell you what they took are those toxidromes. If you could recognize the clinical picture of the patient, that's going to be more helpful than any urine drug screen is. If you have the luxury of knowing what drug they took, you can send a specific level for that drug. Say, for instance, they took Dilantin, you could send a Dilantin level. But you got to know what they took in order to know what to send. Two specific levels that we send on almost all the patients are Tylenol levels and aspirin levels. Namely because these drugs are so readily available and they're often present in combination meds like flu medicines, and their toxicity is pretty bad, and it's also something we can fix if we know about it. So that's the reason we usually are going to order these on all tox patients as well. As an aside, let's just look at the Tylenol level real quick, and that is going to be defined by something called the Rummock-Matthew nomogram, and that plots the time to ingestion on one axis and the Tylenol level on another. And one thing we know about Tylenol is that any ingestion takes some time to show up. So anything that is in the first 4 hours, any level we get then is really not accurate. So we need a level that is at least 4 hours old. So if you get a patient who takes an OD and they come to the ER, go ahead and get a Tylenol level when they come in, but make sure you get one at that 4-hour mark since they ingested as well. With levels of greater than 140 being probably going to cause some toxicity, or possibly, and anything over 200 is pretty sure going to do it. This could guide your management, such as if you want to start an antidote for Tylenol. If you fall out into this probable liver toxicity zone, then you want to definitely start it. You might even want to consider starting it here, but if you're in this zone over here at 8 hours, your level's 50, you probably don't need to use that drug. Another thing to talk about with specific drug levels is whether a drug is acute or chronic ingestion. With acute ingestions, the levels can be pretty high and not cause that much toxicity because it hasn't had that much time to distribute to all the tissues. So you might be tricked by a really high level into thinking things are worse than they normally are. This is going to be the case for younger patients, maybe kids or people who are trying to commit suicide, because they're the ones who are going to take it all at one go. Now, chronic ingestions might be someone who's older and has been taking a medicine, maybe in a higher dose than they should, for a long time, and so that's been building up over the course of time. So it's been distributing into the tissues, and so the serum level may not be that high, but the toxicity can be very high. So it's very important to know, is this an acute ingestion or a chronic ingestion? If it's a chronic ingestion and you're seeing symptoms and the level isn't that high, you should still be worried. So one of our old adages is treat the patient, not the number. And that holds true here as well. Now let's talk about some calculations, the first of which is the anion gap. These calculations can also give you clues as to what the possible drug that was ingested could be. So the anion gap, as you might remember, is going to be the sodium minus the chloride and the bicarb, with a normal range being around 8 to 12. And this is going to be different based on your lab, so I would look at your lab's reference values. So you may remember the mnemonic mud piles for the anion gap, but I'm going to give you an even longer one. It's called metal acid gap. So M stands for methanol or metformin, E is ethylene glycol, T is toluene, A is alcoholic ketoacidosis, L is lactic acidosis, A is aminoglycosides, and really anything else that could cause uremia. C is cyanide or carbon monoxide, I is isoniazid or iron, D is diabetic ketoacidosis, G is a generalized tonic-clonic seizure or any toxin that can cause seizures, A is aspirin, and P is paraldehyde. So this is obviously a much larger and harder to remember mnemonic. Go ahead and go with mud piles if that's the one you know, but remember that there are things outside of mud piles and you might want to look those up if you have a patient who has an anion gap. And now let's talk about the delta gap. And to understand what this is, let's first remember how acids and the buffering system works. So if you have an acidosis, which is going to be evidenced by an increased anion gap, you know that extra acid is going to be buffered by bicarb, and so your bicarb level is going to go down. So anytime your anion gap goes up, we would expect the bicarb level to go down as it acts as the buffer. But what if you have a mixed acid-base picture? How are you going to know what's going on? This is where the delta gap comes into play. Let's say you calculate the anion gap to be about 20, and we're calling normal 12. So then our delta is going to be 8. And let's say the bicarb level is 15, and we know that the normal is about 24. So 24 minus 15 is 9. So our delta for the bicarb is going to be 9. So the delta gap is this 8 minus this 9, and that equals -1. And normal is anything between -6 and 6. Positive 6, that is. Let's take a different scenario now. The anion gap is still 20, but the bicarb is 23. So the delta anion gap we're still going to say is 8, and the delta bicarb 24 minus 23 is 1. So the delta gap is going to be 7. That means the bicarb didn't drop as much as we would have thought it would, so there must be some other alkalosis process going on. So anything greater than +6, there's some sort of metabolic alkalosis going on additionally. Let's take another example. Say again the anion gap is 20, but this time the bicarb is 2. So the anion gap minus 12, we have a delta anion gap of 8. And our delta bicarb is 24 minus 2 equals 22. So our delta gap is 8 minus 22, and that's -14. So what we have now is we have a lot of extra acid than we could have explained with our very, very, very low bicarb. Something else is eating up acid. So a negative, less than -6, says that there is some other metabolic acidosis process going on in addition to whatever's causing our anion gap acidosis. So if you need to, go over that again so you can get that concept down. And the last calculation we'll look at now is the osmolar gap. So say you have an unexplained metabolic acidosis and you have no idea why. It may be worthwhile to calculate the osmolar gap to see if there might be some methanol or ethylene glycol or other toxic alcohol causing this gap. So the first thing you're going to want to do is make sure you add on or send off a measured serum osmoles. And then you want to calculate the serum osmolality using the familiar formula. 2 times the sodium plus the glucose divided by 18 plus the BUN divided by 2.8 plus the ethanol level divided by 4.6. So let's say your measured level comes back at about 300, and you calculate a level of 275, then you know you have an osmolar gap of 25. And anything greater than 10 is abnormal. And if you have an elevated osmolar gap, you want to think that there's some sort of osmotically active substance in there. And some of the common ones are known by this mnemonic Me-Di. Methanol, ethylene glycol, osmotic diuretics, namely mannitol, isopropyl alcohol, and ethanol. So if you have an elevated osmolar gap, you can send off a methanol level, an ethylene glycol level, or an isopropyl alcohol level, and then you can even check to see if whatever level you get back makes up for that gap. There's conversion factors for those as well. Methanol over 3.2, ethylene glycol over 6.2, and isopropanol over 6. Now that you have these levels from the lab, you can plug these in here and see if your new calculated gap is 10 or less, in which case you could explain it that way. Now, let me just say one thing. If you have a normal osmolar gap, that doesn't mean that there are no osmotic agents present. It doesn't work that way. Just if it's high, you better go look for them. Okay, so that's the end of this video on testing. The last one, we're just going to look at various means of decontamination. All right, see you there.